Dr. Turi is an outstanding person who has been a member of our faculty twice here at Cooper, actually back in the early 2000s, and then he came back again a couple years ago. He is a graduate of Harvard College and Columbia University College of Physicians and Surgeons. He then went on to residency in internal medicine at St. Luke's in New York City, where he was chief medical resident. Then he went to the Peter Ben Brigham Hospital, which is now Brigham and Women's Hospital, for his cardiology fellowship, where he also did advanced research at Harvard Medical School. And he, after that, did postdoctoral training in peripheral vascular disease some 10 years later in France. He's been around the world, literally, but he had 10 years at Wayne State University in Detroit, where he started as an assistant professor and then eventually became professor of medicine, and he's been a professor of medicine ever since at University of California, San Diego, Drexel, Cooper the first time, Robert Wood Johnson, Hackensack, and now Cooper the second time. We all know that he was instrumental in bringing the structural heart program to Cooper with both TAVR and left atrial appendage occlusion. You should also know that he's got numerous grants, been the principal investigator on numerous trials over the years, 57 original papers, 115 invited articles and editorials, over 40 book chapters, so a total of over 200 peer-reviewed publications. Without further ado, I want to welcome Zoltan and personally thank him for all of his contributions to patients, to all of us as peers, and to the greater medical community. So thank you, Zoltan. We're looking forward to your talk today.
Okay, thank you, Terry. Apologies. It's typical that I've never had a problem with doing WebEx from here, but here we go. So I talked to Rick and others in the past about doing this, and Cooper is a particularly warm and friendly institution, but I've found it striking for most of the last 17 years that I've been here that people really know very little about each other. I don't know about people's families. They don't know about mine. I don't know what they do, what they're interested in. And that goes for the fellows, and it goes for the faculty and our PAs and so on. And so I've recommended that people, when they give grand rounds or just when they do Thursday morning conference or whenever, at some point in a five-year cycle, do 5 minutes about themselves and, something they're comfortable talking about, their history, their interests, whatever. So I'm going to do this as part of my swan song. I promise this part will only be 5 minutes, and the talk will segue into something that I hope is reasonably academically interesting. But as you know, I'm about to retire in a little over 2 weeks, so I thought I would leave this off and hopefully will not crash and burn, but you'll like the format and keep doing it in the future. So I was born, this is not typical first slide in the talk, it's not CME quality, but I was born behind the Iron Curtain in 1949, so my age. This was Budapest at the time. It was 3.5 years after the Second World War ended, and the city was rubble. It's the chain bridge. It wasn't rebuilt until after I was born. And I remember the rubble. It was Stalin was in charge. It was a police state, and a scary one that even a little child understood. That's me standing in front of our building in Budapest. It's still there, and this was a yellow star house for those who know what that means. I'll come back to that door near the end of this talk. That's me in second grade in 1956, not long before my last day of elementary school and the last day of my life as I knew it in Hungary. That last day at school was October 22nd, 1956, 64 years ago. Because the next day I woke up to the sound of automatic weapons fire, which you've ever heard echoing through a city, and we were right near the center of the city. You won't forget. It was a bloody, messy revolution. That's Stalin's head on a statue. That's about 6 blocks from our house. It means Russians go home. People don't like to be occupied. The time you used to have a Man of the Year. That was the Hungarian freedom fighter. In fairness, there were a lot of young women also. It was mostly young people, and mostly they all died. But Hungary was free for a few weeks, and it was a difficult time to live through for a variety of reasons. But at some point, one night, in the middle of the night in early December, my mom and I got on the burlap in the back of the truck. My dad sat up front. It was a curfew. And I'm going to spare you the details, but a rather adventurous 48 hours. We made it to the border, about 26 kilometers, and spent 2 nights hiking through hills and forest in a very cold, snowy period, dodging patrols, all kinds of things that I don't have time for. But basically, we wound up as refugees in Austria. Being a refugee is not an experience that you can really understand from news reports. It's dirty, it's violent, it's a bad experience, basically. We were eventually shipped, thanks to some refugee agencies, up to northern Germany, put on a World War I troop transport, 11 days over the North Atlantic, normally 5 or 6 days. It was a storm that a movie got made about. But we survived, and we arrived in Brooklyn Harbor, and the classic thing of a sailor lifting me up around 6:30 in the morning so I could see the Statue of Liberty. I was 7 years old. And as resident, we wound up in Camp Kilmer because Ellis Island had been closed the year before. That's in Piscataway on the Rutgers campus, and started our lives in the U.S. And if you sort of imagine refugee life, once you get here, everything is paved in gold. Not true at all. That was the last picture I have of me in '56 at my birthday party before the revolution. And a few months after we got here, you can kind of see in the eyes that the experience was traumatic. In any event, no one separated me from my parents, which should never happen. And eventually, after about 3 years in flop houses and tenements, and not a good experience, my parents were PhDs, learned English, and we settled into a middle-class life. And I would say that a lot of refugees have it infinitely worse than we did, and still do have it infinitely worse. But in any event, grew up, graduated from high school in Livingston, New Jersey, went to Harvard College, as Perry said, my late parents dropping me off. Then after 4 years there, went to medical school at Columbia. This is a summer job, a lot of poor, sad guinea pigs, and feel guilty in retrospect. This is me in medical school. If you look at the guy with the stringy hair and mustache is me. I cleaned up, and that's my medical school graduation. As Perry said, for the next 4 years, I stayed at what was then St. Luke's, is now Mount Sinai West Morningside. And then went back up to the Brigham, where I spent 7 years, 5 of them on faculty. That's the old Brigham. This is what it looks like now. Along the way, I met my wife, and no, we were not married in the cath lab, although that's the cath lab. I did not promise her that, as part of the wedding vows, that I would take her to Detroit, but in fact, 7 of us moved to Detroit. And I promised her, in fact, we'd be back in 2 or 3 years. Missed that by a third of a century. Took over at Harper Hospital, which is Wayne State, and this group from the Beth Israel and the Brigham, and did arguably was my most productive period. Invented a number of catheters, a right heart catheter that's still used, a perfusion balloon catheter that's been supplanted by stents, a transeptal catheter. There were very few of us doing transeptals in that era, and started my work on microvalvuloplasty, which is what I'm going to eventually segue to. Can you guys hear me okay? Hello?
All good.
Yes.
Yeah, okay. So my microvalvuloplasty work, that was my license in Michigan, PBMB. A lot of you have seen that slide. I'm going to repeat very little, hopefully. Did a sabbatical in '99 in France. I thought it'd be good for my fellowship program. I ran the cath lab, but if we taught carotid stenting and peripheral intervention that wasn't done by cardiologists, and very few carotid stents had been done at the time in general. It's a great experience for me and my family. We lived in a little student apartment in Nancy in eastern France. I also worked with Cribier at the time. He, 3 years later, did the first TAVR. Came back, moved to the University of California, San Diego, which Perry mentioned. I ran the John Ross Cath Lab there. It's a beautiful place. I'd probably still be there, but both my wife and I had elderly parents, and we were making random red eyes back, so Shelley Goldberg had just left Cooper for Hahnemann. He invited me to go to join him. Hahnemann was already falling apart, so Joe Perillo took me in, and I ran the IR lab at Cooper initially, which is an unusual job for a cardiologist. I don't recommend it, but it was humbling and interesting. And as Perry said, I did a number of structural procedures. We did the first Watchman on the East Coast and the 4th one in the U.S. That patient is still followed by Rick Ginsburg. But a number of other things. I ran the vascular program and the carotid program before turning that over to Leo's very competent, actually much better hands. And I started the radials here. I've been doing them since '92. I trained in Holland for that. That's Dino Rippo looking disgusted, where I scheduled 6 consecutive radial cats. This is sort of to jumpstart the program. Dino's my good friend. He posed for that picture. And my license plate changed to TAVR, and we did a lot of stuff with early TAVR. Howie Herman across the river and I were the 2 cardiologists who reviewed every single TAVR done in the world for the first 6 years, except for Canada. Up on Dorrance 4, I used to have a lot of, I used to have in a fireproof safe video of every TAVR, some really blood-curdling things early on, which have been solved. And that's kind of a brief summation of my first 10 really very, very productive, very warm, very good years at Cooper. Perry sort of mentioned my excursions to Rutgers and Hackensack. Along the way, so that's on the left, the much younger version to me, my perfusion balloon catheter. I flew airplanes, and that airplane took me coast to coast to various meetings, and I survived that experience. I did a wilderness trip to the Northwest Territories in Canada, a lot of stuff I won't bore you with. But mostly I started working in developing countries as a young man with bicuspid aortic valve disease. Most importantly, that little guy I'm holding was born. That's my late dad in the picture. And I took that little guy and my wife back to that door that I showed you in the first slide that I showed. I'll come back to him in a minute. So with that, hopefully brief introduction, about 7 minutes, I'm going to segue into the subject of my talk, which is what I've learned on the road, basically, and their ethical, cultural, and scientific observations. There are no disclosures relevant. I'm going to talk about bioethics, and so my real disclosure is I'm not an expert in the arena. This is more my experience. And as Perry said, I've pretty much worked all over the world, every continent that's settled. Red is overseas, and blue is the more scary stuff that was done in the U.S. Some important housekeeping. This research was done during a period in which IRB standards were evolving. There were substantial changes in doing research overseas, which we worked hard to try to do. Mitral stenosis is a disease of poor people in developing countries, so there's really no money in it, and so industry doesn't support it. And so the funding came from a variety of cobbled together places, and primarily, or at least a big part, I paid for a significant part of it myself. I'm going to talk briefly about the disease, planning and designing and executing a study overseas, some unexpected observations and lessons in humility that I learned. So you all know the basics of this. It's still group A strep. It has not evolved into being resistant to penicillin, and basically you create antibodies that target various tissues, and it manifests in many ways. And most of you will never see this disease or haven't seen it. But for our purposes, it causes scarring of the valves and causes disease of pretty much everything except the pulmonic valve. That picture is at Camp Kilmer, which was a hotbed, which I told you was where they landed us when we got here in '57. That was a hotbed of rheumatic fever. That's from the Second World War, that picture. Rheumatic mitral facies, that's not a HIPAA violation, that's off the web, which, again, we don't see. This is a set of cartoons that I had in circulation in 2004, basically showing the deformity of the mitral valve with rheumatic heart disease. And again, for the sake of expediency, I'm going to skip the details. But if you think this is an outdated disease that doesn't occur anyplace else, this is from the New York Times in September 2 years ago. This is a young woman with end-stage rheumatic heart disease. I worked in places, the Central Chest Hospital in Bangkok, for example, that has entire wards of people who with end-stage rheumatic heart disease, cirrhosis of the liver from passive congestion, and basically were dying of rheumatic heart disease. It's a nasty business. This is a group from primarily the Bethesda Hospital in Boston, but the Harvard system, who go there. A little quote that she's 78 pounds, this lady, so tiny, I'm afraid she'll fracture getting off the bed. It's a nasty illness if untreated, and we do see it here occasionally. I knew Pat come from my time in Boston, and basically she's saying that this lady is too sick for surgery. This is the group from Harvard who goes and does valve replacements in Rwanda. But they're going to give her Lasix to keep her on an even keel. That doesn't treat very effectively, of course. This is the survival. The blue line, if you don't intervene on mitral stenosis, and you can see it's really poor. This is after the first observation someone has the disease, not when they're that sick. So it's literally a malignancy. There have been attempts to try to fix this problem going back to 1923 when Cutler and Levine at the Brigham published this article in what is now the New England Journal, and they described the closed commissurotomy procedure. They put a metal device in with a bursting suture. This is not open heart. You don't stop the heart. This one little girl survived and lived to adulthood. The next 8 patients died, and they never did it again. And it really wasn't until the 1940s that surgeons came back who had trained in taking shrapnel out of the heart in soldiers in the Second World War. So when they came back, they tried to put it to peaceful use, what they'd learned about operating on beating hearts. And Charles Bailey across the river at Hahnemann did a couple of operations that, these are end-stage patients. The left atrium fell apart when they went in there. He got to be called the butcher of Hahnemann thanks to that. But he did 2 more procedures, the final one up at Episcopal Hospital, and that patient survived. 6 days later, Dwight Harker in Boston performed his first case. And this whole treatment for mitral stenosis and really cardiac surgery began with this. And this is a good procedure. It's a blade that you can stick into the beating heart to open the valve. But it's this procedure with this metal dilator that you use that you put into the apex of the beating heart. And you basically spread it. I'll spare you the details, but it is a very good, very cheap instrument to use, and it does have reasonable results. This is a picture of what they were doing in Hyderabad when I got there in the 1980s. And the results are decent. So basically, you see there about a 20% mortality. This study, which was done by Stanley Johns in Vellore, India, is notorious for poor follow-up, so we don't know what the real results are. But we know that basically in that early period, if you had sick people and you didn't operate on them, you didn't do anything with them, they had 40% 1-year mortality. It's a nasty illness if once it's severe and not treated. The alternatives to closed commissurotomy were basically open commissurotomy, but you had to stop the heart, put the patient on a heart-lung machine. Very few people in the U.S. do this operation anymore, but you can fix a relatively healthy rheumatic valve with a repair procedure that normally is considered a contraindication, but it's a different kind of repair. You basically split the commissures, and it's pretty effective, but again, it isn't done anymore here. And we mostly replace valves, and that's mostly thanks to work of pioneers like John Gibbon across the river with the heart-lung machine. The problem with that is it's expensive, and this is a disease of developing countries, and expensive doesn't go well together. This is a membrane oxygenator. In one day, this is in November 2016, in the ports of Delhi and Bombay. These were the membrane oxygenator cargo, basically. You can buy these things. You can buy them on the market. Of course, that means that you can buy it on eBay. They seriously do have everything, but it's a small fortune for developing countries, so it's not practical. And prosthetic valves in developing countries, it's about 5,000 in the U.S. By the time middlemen mark it up, it's at least twice as much. So a couple of countries, particularly India, have come up with indigenous valves. They're not very good. They're mechanical. And so they typically put them like on 2 or 3 milligrams of warfarin. There's no testing available in rural areas. And they have the world's highest rates of prosthetic thrombosis. Tissue valves have to be imported. They're very expensive. They're not durable. So there was no cheap, good medical or surgical solution really until the 1980s when balloon inflation was first done. And this was, the Inouye balloon was not available. And so we did double ballooning until the 1990s. And that's most of our work was done with double balloon. It's really complicated and it's sort of elegant, but it's messy. Nevertheless, in '87, the cardiologists were just kind of feeling their oats on coronary intervention. They thought this would be the next great thing. Bill Roberts at the American Journal of Cardiology had this editorial. I have a T-shirt that says with this logo on it. But it really got ahead of itself. A few people were trying it. Not a lot of people knew how to do this. But I had gone through, I was at the Brigham, and my boss, Dr. Brownwald, after CABG was first done by Favaloro at the Cleveland Clinic, wrote this editorial, not to let the genie escape from the bottle. In other words, do a randomized trial before you start doing this procedure widespread. He wrote the same editorial about direct thrombolytic therapy, and so I thought before he wrote another editorial about valve interventions, it was tailor-made for me. I had gone to the Brigham because I was interested in valve disease. I was an interventional cardiologist, and I had done 7 years of clinical trials with Dr. Brownwald. So the issues were, it's breakthrough technology. There's always a problem for a clinical trial. There's a low prevalence of rheumatic heart disease in the United States, so it's a terrible place to do it. It would take a decade or more. It would cost millions, a lot of centers, a lot of IRBs. We might never get it done, and certainly would have trouble getting it funded. If you work in a developing country, there are cultural and clinical issues, which I'm really focusing on, but lots of obstacles to high-level clinical trials. They have a lot of patients. We could do it in a single site, only a few operators, which is a big deal because you decrease the number of learning curves you have to go through. And we could do it very fast and relatively cheaply. So if you're studying early breakthrough technology, you expose patients to the risk of the operating learning curve. And so you have a higher complication rate, and that contaminates your comparison. So we were comparing ballooning on the left with the closed commissurotomy technique on the right. And ballooning was brand new. It was less than a year old, whereas there was 40 years of experience with tubs dilators and the like. So, it's not an apples-to-apples comparison. We had to find a suitable site. So we needed a lot of disease there, interesting clinical trials. People would be willing to turn over their institution. And believe me, all over the world, the personalities and politics are the same. And we needed adequate equipment and a database, which are very unusual in developing countries. So disease prevalence for rheumatic heart disease, Jonathan Carapetis, who I think is the world's expert in Darwin, Australia. You see the big blobs are in Africa, India, and Asia. And of course, we went to India. We went to Hyderabad on the Deccan Plateau in southern India. That's the Nizam's Institute of Medical Sciences at the bottom right. I'll talk about the Nizam's in a second. And Dr. Somaraju, who's my hero and friend and colleague and collaborator, who spent 6 months with us at the Brigham doing sabbaticals, so we knew each other. These were the Nizams. They were fabulously wealthy. When we got to Hyderabad, it was a poor city with a mix of three-wheeled and four-wheeled vehicles and no lane rules. You could drive on either side, and cattle and all kinds of things. And at the same time, the city had enormous luxury as being a diamond and gold and pearl trading center. That's the Kohinoor diamond, which of course the British stole, but 191 carats. And that's the Nizam's lunchbox there, which in 2018 was stolen. But if that's your lunchbox, you're quite wealthy. So we spent 6 months negotiating with them. They were leery of Americans. They had experience with Americans coming there or other Westerners, learning on their patients, exposing their patients to their complications, and then going back to their own countries, having basically exploited the poor people elsewhere. And believe me, that still goes on. There's a long history of abuse in developing countries, including in India. One of the studies cited there basically had a control group where women were not screened for cervical cancer, and people are cheap and easy human guinea pigs, unfortunately, and this stuff's still going on. These articles are from the last 20 years. So there's a real tradition and a real need for caution in that part of the world. It is better now. There are some regulations. How do we identify our patients? Well, we went to a medical camp, or they went to a medical camp in a nearby village, and they took an echo machine with them. And they would find a single patient with mitral stenosis and then ask them, the people, if there was anybody around with similar symptoms. And there was an infinite number of patients with mitral stenosis in that era. Our first trip was in 1987. We wanted to get used to each other, familiarize ourselves with their equipment, but we wanted to bond, and we wanted to develop protocol for an actual study. It was planned for October 87. They asked us how many patients we wanted. I said 50 patients with severe MS in sinus rhythm and no more than moderate pulmonary hypertension. So they admitted 83 such patients on 4 wards on October 2nd of 1987. We shipped our equipment, our physiologic monitors, all kinds of other stuff over there, quite expensive, by the way. And these were wards of mitral stenosis patients, an incredibly rich experience to which I exposed a number of my fellows over the years. This is the Indian Express from exactly 33 years ago today. That's me in the picture doing a mitral valvuloplasty. On that visit, we had a meeting with the health minister, and the health minister said, "Thank you for bringing this wonderful technology to our country." And I wanted to say something polite. It was on TV, so I said, "You're very kind, but it's what you're doing, giving patients penicillin, that will make the biggest difference." And that was accurate then, still accurate. There was a young public health officer next to me who leaned over and said, unfortunately, it's October, so right now we're out of penicillin. So here's something that's dirt cheap, but there's an annual budget for it, and they were out of penicillin. So these are the problems in developing countries. Other observations on that first trip, they had no experience of doing formal research of the kind that we expect. There's no culture of reporting every detail. It's not just Indian. There are many developing countries, there's cultural reluctance to deliver bad news. In fact, we learned there was a patient waiting for us during our first visit with mitral stenosis and profound depression, which, by the way, is not that uncommon. And he hung himself. And we discovered this in the local newspaper several days later by seeing a picture of this guy with the noose around his neck, and it mentioned that there were these doctors from the U.S., and he was distraught because they hadn't treated him yet. So we had to deal with this because, of course, for high-quality research, we need every detail. We need to see all the nasty scars and moles and so on, not just the good news. This was the first randomized trial we did starting in February. I don't know if you can see my cursor, but you'll see that one of my co-investigators was Priscilla. And this was the lead article in the March issue of Circulation in 1991. I highlight here that the study was approved by the Nizam's Institute of Medical Sciences, IRB. Now, it's important to realize that they had no IRB when we first went there, so we studied what was required, and we formed an IRB, and we had all these various people, a clergyman and community representatives and so on. We basically did our best, okay? We didn't do as well as we thought in retrospect, and, the subsequent guidelines say you really should have people with experience and expertise, which, a lot of those people didn't have because they didn't do this kind of study there. You needed diversity of backgrounds. I don't think we really had that. And knowledge and experience with vulnerable populations, which this certainly was. There's a wonderful editorial by Marcia Angel on ethical issues with doing research in developing countries. This is actually a year after, or actually the year we started our work. And I want to highlight a couple things. And she's saying that, researchers would be tempted if they're working there to short-circuit the requirements of protecting human subjects. So there'd be a true imperialism in the sense of exploitation. But on the other hand, in terms of ethical imperialism, you have to accommodate local sensitivities. So it may be necessary, for example, to obtain permission, and down here, from a husband to enroll his wife. So in 2020 in the U.S., I think most of us would find that to a large degree obnoxious or not politically correct at a minimum. But again, we weren't working in the U.S., and it's an ethical imperialism to impose our standards on them. And again, I'm not a bioethicist, but we struggled with this stuff. So the consent process, the patients met as a group rather than one-on-one. We made sure that it was written in Telugu, and the presentation was in Telugu. I've learned some Telugu along the way, by the way. Not many Westerners can say that. And we had to explain randomization and the procedure and the risks and all that sort of stuff in a culture where there is this patrician trusting of physicians, not so much anymore, but certainly then. They chose representatives, which is what they wanted to do, probably the better educated, more articulate of them. And one of them said, this sounds like a lottery. And when I heard that, I thought, good, they understand randomization, okay? Women in particular had husbands or fathers with them who signed the consent. The patients signed the consent, but they really leaned on these folks. And the question is, was this acceptable? And that's what we reached back to the Marcia Angel editorial for. So the first trial was randomized balloon to surgery. So the old closed commissurotomy, the Tubbs dilator, which everybody had experience. And this was, we assessed patients at baseline 1 week. So they stayed in the hospital for that 6 months, 3, 7, and 10 years. And I highlight that for hemodynamics, we did not just echo, but also cardiac cath, because in that era, echo was really still relatively primitive. And we had unhappy patients and staff. The surgeons thought that the randomization was just a blind, that we were in fact going to take high-risk patients and give them to them and do the low-risk patients to make us look good and them look bad internationally. And despite our written method, which is that both groups would screen every patient, they had to agree the patient was a suitable candidate, and only then would they be randomized. Well, what happened was, just as a fluke, the first 7 patients randomized to surgery. This caused the patients to rebel because they really wanted ballooning. Nobody, even in that era, especially in that era, but in any era, wants a big scar on their chest instead of having something done with just a balloon and while they're awake. It reassured the surgeons because they were getting all these easy cases. And then, of course, through the next 4, everything reversed to the mean, randomized to ballooning, and so everybody kind of settled in. There were only 40 patients in the study, but it was the first randomized study of any heart surgery, valve surgery technique. And if you go to Ted Sullivan presenting the COAP data or the Everest data, he'll say this was, theirs was the second randomized trial of valve surgery versus a percutaneous intervention. And this was actually quite ambitious because we did it in a 2-week period. And, I'll point out these were young patients, typical of an Indian or a developing country mitral stenosis population. They had severe to very severe, what we categorize now mitral stenosis, and beautiful supple heart valves, echo scores of 7 to 8. Everything was, there's a lot of work. We kept all the data with, blinded information. That's Vince Reyes, one of my fellows, with several cardiologists from India and doing preliminary measurements, but ultimately the planimetry and everything else was done by a blinded cardiologist, Peter Farkas, in the U.S. And the results were good, but not great. So we inflated our balloons and settled for valve areas about 1.5, which meet the criteria for successful dilatation. But we were purposely conservative, and the reason was if we pushed it too hard, we would get valve areas of 1.8 or 2. But we would get a certain percentage of patients with torrential MR, which is a catastrophe if you have to do a mechanical valve in 1988 in a developing country because, again, they can't get anticoagulation there in any proper fashion. So we were purposely conservative. This was kind of the follow-up. I'll go to the details of the next study in a minute, but the bottom line is that 36 patients still around and available to us at 10 years, 33 came back for follow-up, including CAT, which is quite remarkable. I'll show you, I'll go into more detail on this. The bottom line was the complication rate was low and the efficacy and safety was equal to closed surgical commissurotomy. The limitations of this first study were these are young ideal patients, relatively conservative effort, and closed commissurotomy is just not done in industrialized nations. So we knew that would be a criticism. It was the basis for the reaction of the paper by the New England Journal in '91. But by that time, we had already launched our second study, which was a larger study comparing open commissurotomy, so direct vision, membrane oxygenators, all that stuff needed, to balloon valvuloplasty. And that started in '89. It was almost exactly 36 years ago today. I'm sorry, yeah, it was published 26 years ago today, sorry. And once again, you'll notice that from the Wayne State folks, Priscilla was one of the investigators. Dr. Somaraj, who is down here, was the lead investigator from there. And here we got consent from both IRBs, our own as well as the Nizam's Institute. That is, in fact, the standard now. You don't just go off and do research someplace else without your own institution vetting it. And this was a 60-patient study. It was then the biggest study, randomized study of valve disease ever done. And we had a remarkable follow-up. So 60 patients, 1 week, 6 months, 3 years, and 7 years. One lady died at 2.5 years of a stroke in a remote village. They put her to bed. She didn't hydrate, and she basically died after 3 or 4 days. Her son, however, when we did the 3-year follow-up, and again, all of these, we went back and did them all ourselves. So because we enrolled them in a bolus, we could follow them in a bolus. And even that lady's son came and visited us and gave us details on what happened to him. So remarkable follow-up, which is a plus and a minus, and I'll talk about it. And here we're comparing ballooning to open commissurotomy. And again, we did this during a 3-week period. And you notice literally perfect follow-up. Perfect is usually too good, and there are issues with that. So these were the results, and out through 7 years, not only, we started redilating at 3 years, but you'll notice that ballooning is always superior to surgery. And that wasn't our hypothesis, so we had to explain it. And I think the reason is that when you're in the cath lab doing these procedures, you have an instant feedback loop. You know if you need to dilate a little more, or if you're getting a little bit of MR and you should stop. And the surgeons don't have that, especially in that era when they didn't have TE. So here, ballooning was actually superior, and this was the editorial by Blaise Carabello, whom I've had at Cooper a number of times over the years. So we went from that original 1923 closed commissurotomy approach to open commissurotomy to balloon dilatation, and that was the editorial about our paper in 1994. And in fact, the guidelines, if you look at it, basically reference our paper as the reason why balloon valvuloplasty is a class 1 indication for ideal anatomy. But we learned other stuff, and that's kind of what I want to finish with, because this is the more important stuff. Economic, ethical issues, did we really do good, and some aftermath comments. So these are economic issues. You know, we bought all these disposables and threw them away, and then they, of course, would wash them. My fellow went back into the back room and noticed that the gloves he'd thrown in the garbage can as ugly Americans had been harvested and were being cleaned and dried in the back room. The irony now is that they manufacture the gloves we use here, sometimes in India, and they dispose of their gloves. But in that era, the idea of a disposable was an oxymoron in a developing country. We compared the costs, and basically a closed commissurotomy in India in that era cost about $300, as opposed to surgery in the U.S., which cost an infinite amount of money, and it's probably 5 times as much now. The thought was we don't have a lot of good mitral valves to dilate in the U.S., and we should probably just put those folks on 747s and send them to India as a cost-effective measure and forget this balloon business, because this procedure, if you recall, was really pretty good, closed commissurotomy. Now, our follow-up is really good, and maybe too good. So if you look at closed commissurotomy blue, open commissurotomy, or the combination, you can see that we had 90+% follow-up. And there's some real issues. You know, how do you get perfect follow-up? Well, you worry, you always worry that there's some undue influence you're exerting on a vulnerable population. This is Clara Moss, and this is the scandal that went around the Walter Reed experiments with the yellow fever around 1900. People were given $100 in gold, and if they died from the experiment, their families were given the money. Clara Moss was a nurse from New Jersey. There's a hospital in North Jersey named after her who indeed died, and this drew a lot of ethics folks' attentions even 120 years ago. We compensated patients for travel to visit us. If you're a poor person trying to travel in India, what's even cheaper than a bus is riding on top of trucks. Quite dangerous, even if you're not riding on top of it. And, you know, we paid them for their trips and for some loss of income. And we had to struggle not to give them too much money because it wasn't a lot of money. Our hearts went out to these people, but we had to be careful. This is Barbara Fromm, my biostatistician, and also sort of substituting as a social worker. They loved this lady. She was the wife of our chief of surgery, came on a number of these trips. And, you know, there was this Western lady, that's our translator, Sister Mercy Augustine, and these poor women from villages had this Western lady come and talk to them about their lives. And the lives of a woman in a poor village in India is very difficult. And here you can see her on the right talking to her about how difficult is it to wring out the wash, because that's, of course, an isometric exercise can be tough on patients. And they bonded with her. They had her pictures. They always wanted a picture taken with her. They put it up displayed in their apartments or dwellings. And that's a kind of inducement as well. We learned some other things. So here's a lady after closed commissurotomy. She's splinting. She's miserable. That's what the chest looks like. This is a happy-looking fellow after a balloon dilatation. So there's some patient comfort, issues, avoidance of thoracotomy, perhaps some other issues, cost, at least in the U.S., but certainly not in India. And something that we didn't realize and was humbling and we needed to learn, which is that scar on the chest is not a benign thing. And mind you, this is from only 3 years ago. Okay, there's a whole issue of dowries. About 8,000 women a year die because of dowry murders in India. You know, if you have a scar on the chest, you're damaged goods. It's something we didn't really appreciate. I don't want to oversimplify it. This is not uniformly. First of all, it's not an Indian thing. It's all over the world. Second, it's oversimplifying, but certainly among poor people, dowry for daughters is a big issue in terms of trying to save money so they can marry off your daughter. And if you're scarred or somehow, you know, not going to be able to work and maybe not able to have children, et cetera, the dowry rises. It's unaffordable for poor people who then become unmarriageable, who have no children and potentially have a life of poverty with nobody to care for them. So how do you address this? Well, when we became aware of this, we basically stopped randomizing women into the study. And we would do just, you know, unrandomized, any patient that had come to us and was going to be randomized at that point, we just did the balloon procedure on them. The aftermath of all of this, well, a lot has changed. So now there's a central research clearance agency in India. There's a medical license requirement. At the time you could do neurosurgery, having never gone to medical school. The volume of studies has risen enormously by the last data that I have data. And these are federal-wide assurance on the left and IRB certification on the Office of Human Research Protection, part of the Health and Human Services in the U.S., recognizing the IRBs of various hospitals in India that I worked with in Hyderabad. So it's a different era. They've done a lot of TIMI studies there, et cetera. But we're talking about 33 years ago. This is the research crew about 8 years ago when I was bringing a study to Hyderabad. So they have real research infrastructure. Aftermath, Dr. Somaraju and I did the chapter on rheumatic fever for several editions in Brownwell textbook. Hyderabad doesn't look like anymore like I showed you. It's now Cyber City with GE and Oracle and Microsoft and a whole bunch of companies with beautiful high-rise buildings there. Incidence of rheumatic fever is decreasing. And part of it is that every tea stall in remote villages sells penicillin dirt cheap. And moms know that when their kids have a sore throat to give it to them. The bug has not evolved to be resistant to penicillin, which is sort of amazing. And so it is declining. I went to, when I did this book chapter, I went to look for rheumatic fever cases in Hyderabad, and we had trouble finding them. That doesn't mean things have gone really, really good. I worked at the Gandhi Hospital. It's an incredible place. These are some pictures we took there. But basically, something like a power outage killed 21 people there. 3/4 of providers have really no healthcare training. Only 4% have MDs. I worked in Bangladesh, and only 3% of the population ever sees a trained healthcare provider. It's 150 million people. It's really quite amazing. This is working in Bangladesh. I'll spare you the details, but it was really horrendous. That's me about 20 years ago in the Talan Cribier, and my PA, John McGinnity, in Dhaka. We've exported some of the evils of our healthcare system, so there are plenty of these beautiful steel and glass high-rise buildings for providing healthcare to wealthy people. There is now an emphasis on, advertising hospitals, cost-effective cardiac care. Studying the USA is another issue, but these are just pictures I took from various rides some years back in India. So it's kind of a mixed environment. I had the privilege of an audience with Dr. Abdul Kalam, who's the founder of the Indian ballistic missile industry, who, when he retired from that, got very interested in healthcare, and he managed to have the lasers that were being used he basically turned swords into plowshares. He got those lasers to be used for an indigenous laser. It looks like my friend Somaraju, but basically he was very interested in quality access to healthcare, and he became president of India. And president there is not the prime minister, so it's not a politically powerful title, but it is a major prestigious title. We spent several hours talking about all of this, so a wonderful man who's since died. Did we do a good thing? Developing countries, I learned this from in Kenya, in Nairobi, from the health minister, which is they need IV fluids for babies and HIV education. And it was my conclusion, but looking at their 5-year plans, et cetera, the last thing they needed were people like me going to do a dozen microvasculoplasties, leaving people behind who weren't really trained. And really, for the cost of that potential, you can spend your dollars much better. And the other thing is I became aware that balloon valvuloplasty is so appealing, patients like it so much, physicians like it so much, that they've essentially stopped doing closed commissurotomy, which is cheaper, and you didn't need to have a cath lab. So I've questioned whether everything that, and we brought balloon valvuloplasty to South India, and that is now the dominant procedure. They reuse the balloons, et cetera. But you have to question whether what you did really was as good as you think it was. Some pictures from 30 years of working in India. This is why we're still doing a lot of ladies. That's Barbara Fromm. That's Sister Mercy Augustine. And 16 or 18 patients. This was a great joy of this. This was a young girl. When we dilated her, she came back at 7 years with her husband and child. And one of the ways we learned about the scar issue is that not her, but a number of our patients didn't want us to tell their families that they had had this procedure because they didn't pay for it in their dowry. This is a family, a middle-class family who had us to their apartment in Hyderabad. Yes, they had a picture of us on their mantle. Very nice people. This is me before. This is a before picture of me back in the late 80s, early 90s. before I discovered masala dosa and other just wonderful Indian food. And as to that lunchbox, the thieves ate from the lunchbox, but they did recover the lunchbox by late September of that year. I took a number of people to India with me. This is Aveen Yussel and Jat Scaff from Cooper. This is not India. This is Panama. This is Aveen in Vietnam, and Dr. Lee, who's the head of surgery at Rutgers, where I was at the time. This is Shukri David, who now is endowed chair and is head of the cardiac program in outside Detroit when we were passing through Bangkok on our way to India. This is someone you should know. 30 plus years ago, there's a tradition to give you garlands of flowers at the end of these trips. These are the folks I want to thank. Unfortunately, a number of them have passed away since then. Peter did our blinded data analyses. It's painstaking. And this is in the courtyard of the Nizam's Institute, various people, wonderful people. And also the people from Hyderabad. This is my PA, John McGinnity. That's actually Priscilla in the background there. But wonderful people without whom none of this work would have been done. And then finally, I want to thank all of you for 12 great years of the last 17. You've carried the ball in beautiful ways. I've come back to watch, Sajad and Janah and others doing, and Simon doing the structural cases. Leo is running this wonderful vascular program. I don't want to leave out anybody, so I'll stop there. But a number of you have been incredibly kind to me and supportive and patient, even if I'm a curmudgeon at Thursday morning conference. I especially want to thank the fellows for humoring me and putting up with me the last year and 4 months. It was one of the best experiences of my. I want to thank Bill Clark, long gone, who was my chief at St. Luke's and founded the Arthritis Foundation. A wonderful person without whom I don't think my career would be anything like it's been. And then Dr. Bromwald, Wynn, Tony DeMaria, were all very supportive. I'd be remiss not to thank Joe and Jim Koromilas at Rutgers, who's a wonderful person and cardiologist and teacher. But most of all, I want to thank my patients. This lady was my patient at Cooper. I stented her carotids and vertebrals and renals and SMA. She was a vasculopath. Ultimately, and her coronaries, and ultimately she had a TAVR. And what I want to point out in this picture, which I truly love, is the laying on of hands. The reward that hopefully a patient, but certainly a physician gets from the warmth and affection and trust that patients put in us as we learn at their peril and also at their patients, and as we get to know them and they get to know us. And then, so my last slide, I managed to finish on time anyway, is the best part of this tail end of my career. As I said, I'm only here for another 17 days or so. But tomorrow, I will be heading up to Boston. We're slowly keeping I'm slowly keeping my promise to my wife. And so we're going to have an apartment up there in a couple of weeks, but we're going to still live in Haddonfield for the foreseeable future, where I'm going to see my son, that little boy who you saw in front of the door, who now is the father of my 6-week-old grandchild. So thank you very much.
Thank you, Dr. Turi. Zoltan, it was absolutely more than we could have ever asked for. It was a beautiful depiction of a person's life, but with the context of medical care and humanity. And really, I think we're all touched and moved by that. So I want to thank you very much. You did finish indeed on time. There may be some questions, though, from the audience. So if anybody has questions, we'll try to work through that with the Zoom. We'll have to kind of go one at a time, but I can't see hands or anything. So if anybody has a question, would they please speak up?
Hi, Zoltan. This is Rick. Thanks for a wonderful talk. But I just want to ask about your conclusion. Seemed mixed about efforts like this of Western physicians bringing at least high-tech things to poorer countries that don't have the resources. So is the best thing to support the supplies of low-tech things like IV fluids and efforts to treat and prevent infectious disease, or can we do everything?
I don't think we can do everything, and for any given dollar, I think we accomplish a lot more by supporting reputable aid agencies, and there's a lot of health care to be delivered, and I became, you know, I mean, I'm a curmudgeon to start with, but I became somewhat sort of pessimistic about what we were really accomplishing. So, for example, that the trip to Panama with Naveen and Jad, I had gone there once before. They were incredibly grateful because the guy who'd gone there to do mitral valvuloplasties a couple of years earlier was a very good guy whom I really respect. A couple of people had died, and you know, there were bad things happen. And so when I went, you know, it was luck because that guy's really good. We had a bunch of patients do very well. And when I went back the next time with Naveen and Jad, their cath lab went down. And so we were there, we had started, and we couldn't do the procedures. And there were other hospitals we could have gone to, but the commercial interest there and the politics were such that, you know, they didn't want us to do it. They wanted to learn how to do it so they could make it a procedure there. And, you know, in Kenya, we train people, and then, you know, they take what equipment we leave, and they bring in paying patients to do it on. They're not well trained, so it's not a favor to the paying patients. And what you'd like to do is charity, you know, give pacemakers or other stuff. There are all kinds of commercial issues in developing countries. That's more than you want to know, but the bottom line is, yes, if you were going to donate something, I mostly stopped doing it. I worked in Vietnam most recently, but I'm not so optimistic. I think we should give our money to aid agencies that deliver basic care.
That's not to say, obviously, that the 30 patients who you treated with balloon valvuloplasty in India in the early 90s aren't eternally grateful to you. So that's, you know,
and the truth is that they've learned to do it very well. They use an indigenous balloon. That's a whole different issue. And they do, you know, they do thousands of procedures still, although even they're running out of rheumatic fever. And so, yes, it's worth doing these things in developing countries. But if you have X dollars to spend and the country has abject poverty, this is probably not the first thing on my list, I guess, is what I'm saying.
Sure. Thanks.
Great.
Sorry about the beginning. It's the first time that's happened, but at least we solved it.
Well, I'll ask a question. No, it was perfect. It worked out very, very well. I certainly enjoyed it. I know everybody else did. I'll ask a question, though. So, you know, you've told us your life story, and it's still to be continued, obviously, but it's very beautiful. And seeing the 3 generations of the Turis, really special. What lessons, though, can you give us for the future of the world? You know, there's still strife and turmoil all over the world. Still, people are impoverished. People are imprisoned. We haven't learned enough. What does the future look like? You've shown us the past. What do you think is going to happen?
Well, I'll stay out of politics. You know, I don't have a better crystal ball than anybody else. If I were starting again and my real mission was healthcare in developing countries, you know, this was fun. People lead really useful expeditions, but really it is political. It's allocation of resources. It's worrying about all kinds of things that require mostly charity and charitable contributions and charitable work. As an individual physician, I probably could have accomplished more by being a pediatrician and giving my time working in Africa. I'm not too optimistic. The world is not only more polarized, but also poor people are getting poorer, and we have just a horrendous amount of maternal fetal deaths and short life expectancies, people dying of hunger. As physicians, we have great training, but we focus here on can we find a better ACE inhibitor and that sort of stuff, and that is such a tiny portion of what mankind needs that I think it's important for us to do what we do. We need to provide first-class health care for our own people. But if you're asking on a worldwide basis, we have a really terrible allocation of resources. And the people who suffer from things like global warming are, of course, the poorest people.
Yeah. I asked that question for obvious reasons. I know there's no answer, but I think hopefully some of the people on this call the generations to come will find some ways, as you tried to do, to improve things, not just for some people, but maybe for the whole world. It's a lofty goal. We still have to support all human beings and treat them with respect. So, I learned a lot from your lessons. Not so much all the medicine that we know, but about humanity. I think that's a deeper message and a very beautiful thing. Anybody else have a question? Maybe we'll allow for another 3 minutes. If there's another question, speak up. Also, fill out your forms for CME. All right, well, if not, I certainly want to thank you again, not for today's lecture, but for 40 years plus of all the things that you've done and for more to come. We hope you enjoy your grandson, and we know that the world's a little better place because you were in it. So I'm glad to have known you and to continue to know you and call you a friend. So thanks, Zoltan. Everybody at Cooper is grateful to you.
I'll still be at Thursday morning conference with the nuisance.
Good. All right. Well, thanks, everybody. We'll have grand rounds in November. Dr. Heinz will be speaking, so stay tuned. Everybody have a great day. Thank you.
Zoltan, congratulations.
Thank you. Congratulations.
Thank you, guys.